I'm delighted to introduce our first speaker, who's Harsha Shah. Harsha is going to come and talk to us today. Come forward, Harsha. I've forgotten what you're talking about. But anyway, Harsha's done a fantastic PhD looking at early pregnancy scanning in the first trimester, and really sort of saying what should you be able to see and what can you see, because very often when we're particularly working in early pregnancy, we kind of just look at the embryo, measure it, is it viable? But there's an awful lot more we can do. And I think also as a sort of first lecture, it's useful to look at almost like we're talking about the anatomy and some of those things as well. So Harsha, I'm delighted to introduce you. Harsha is now self-spec trainee in fetal medicine at Imperial, having completed her PhD. So she has gone to the dark side, but there is still hope for her. Over to you, Harsha.
Thank you. Good morning. Thank you very much for having me, Prof, and for the invitation to speak. And I'm glad that although I've moved to the dark side, I still get an invite to these meetings.
Last one.
All right, noted. I wanted to have a bit of a show of hands at the beginning, please. So who here works in early pregnancy exclusively? Or majority of their time spent working in an early pregnancy unit? And in fetal medicine? In gynecology? I don't know what you're all doing. Okay, perfect. Obstetrics? Okay, perfect. So my talk's kind of based on very much the first trimester, and hopefully will be interesting to those of you who are doing gynae and obs, because it's not an area that lots of people are looking at. So the first trimester scan, you see a patient in the early pregnancy unit. She's 8 or 9 weeks gestation. She comes in with a bit of bleeding. What do? Transvaginal ultrasound once you've taken a history. And typically, you'll get this as your first image. You'll show that it's a intrauterine pregnancy. You'll check the viability. You'll measure the crown rump length, or you'll measure a length that you can get at whatever gestation you're scanning at. And then you'll look at the ovaries. Prof, I've got pictures of ovaries on there. You'll be pleased to see. I found them once. And that's what the majority of us are doing in the early pregnancy unit. We're doing a very quick scan, we're checking viability, we're making sure there's no, big subchorionic hematoma or anything else of concern, and we're sending the patients off and saying, the next time we'll see you will be if you have any further concerns or at your dating scan, because the question they always ask you is, how many weeks am I, and can you tell me anything more about it? And you say, oh, you'll have your dating scan at 12 weeks. It's a real opportunity, though, this scan that we do in early pregnancy. And I think that we have to remember that every time we have contact with a patient, in any setting, and particularly within early pregnancy, it's an opportunity to learn more about this pregnancy, about this baby, and give the woman and the couple as much information as we can give them about their pregnancy. So as well as confirming viability and seeing if it's a singleton or multiple pregnancy and looking at the gestational age, I urge you to start looking at the structures of the baby, because actually even by, 11, 12 weeks, but earlier, you can start to see the anatomy. It is there to be seen. It is developed. I think when we talk about early pregnancy, though, we have to be really clear about what we're talking about, because the embryo and fetus are developing rapidly in the first trimester, and actually what you're seeing at 6, 7 weeks gestation is very different to what you're seeing at 11 or 12 or 13 weeks gestation. So you've got to have an understanding of what's morphologically normal at each gestational age in the first trimester, because it's different. If you scan a woman at 18 weeks versus 20 weeks, things are very similar, but 7 versus 12 are very different. So I want a guess, not from the people who know, though, who've scanned with us in the unit. How many weeks gestation do we think this embryo model is, and what anatomy can you see? Shout out. Right, so the first one was spot on. So 10 weeks gestation, okay? That's a teaspoon there, just to show you the size of what an embryo looks like at that gestation. So it's very small, but there's a lot to be seen. And I'm actually going to take you back one further. So if you look to the embryo to the left of it at 9 weeks, that's kind of half the size of that teaspoon. This is what you can see at 9 weeks. So this is just a regular 2D transvaginal ultrasound. You can see the fluid-filled spaces, the ventricles in the brain. You can start to see the spine forming there. If I scroll and go to a transverse section, you can assess the 2 halves of the brain. You go down, you can see individual fingers there very clearly, the fetal heart pulsations. Scroll down further, you can see the cord insertion, and then we come down and you can see the feet. And the patient actually coughed at this moment and the fetus moved, and you can see the feet coming apart and coming back together. And you can see the legs and limbs moving very, very freely. So, if at 9 weeks gestation, if this baby had mermaid syndrome or serinamelia, you would be able to see that, because you've clearly seen those 2 legs and you've seen those 2 feet and you've seen them come apart separately. So it's an opportunity. If only we could warn a patient at this gestation as opposed to them waiting till 12 weeks or 20 weeks. So 10 weeks, what can you see here? You can see the spine, you can see the heart beating clearly, you can start to see the diaphragm developing. If I go back to a still, so the very first image, the first kind of bit that you saw of that video, I can tell you there the arrows are pointed at the kidneys. What does 3D add? So if you take a volume of this fetus, this is what you get, and then if you apply some rendering to it and you scroll through, you can see these structures, which are the kidneys. Now you're going to say, Harsha, prove that to me, and we'll come on to that. But let's talk a little bit more about 3D and what 3D might add. So the first trimester is an amazing time to take 3D volumes because you can encompass the entire fetus in a single sweep, which you can't do at later gestations. And so you can assess a lot of the anatomy in a single volume. Now, this is how I would suggest that you take a volume. So you optimize your 2D image first because your 3D is entirely reliant on your 3D. You increase the depth, but don't zoom because that's going to reduce the quality of your volume. You set the scan quality. You have your scan angle as small as possible so that you're not getting in lots of things that you're not interested in. If you're assessing transabdominally, then I typically ask the patient just to hold their breath for a moment, and then you can apply some post-processing rendering. So this is what you typically get. I wondered actually, is it possible to have the lights put down a little bit, just for the rest of the...
It means the camera image is...
Oh, I see. Okay. Nobody wants to see me, really, but okay.
For Harsha or the pictures?
Sorry?
You lose the image for the speaker,
Yes.
or... Well, it doesn't
Oh,
matter.
that doesn't matter. That's fine, because the pictures will come up much better if the lights are lower. Thank you. So when you take a 3D volume, you typically get this, which is the MPR view. Now, I don't know about you, and I don't know who... Is anybody used to using this view routinely? No, it's really hard to use. There are lots of things that you've got to fiddle with, and then you think that you've seen what you want to see, and then instantly it changes. It's just hard to process this view. You do get, however, a rendered view, and I think that's the view that we should be focusing on because that's very much more straightforward to use than the MPR view. Now, you'll all be familiar with traditional 3D imaging, and you know that all the machines now have these fancy rendering modes on them. I'm going to talk to you about a few of them that I'm going to show you in these slides, but they're very similar on whichever machine you use. So the first rendering mode that you can apply on this machine is called realistic view, and that's where you get this more kind of real or lifelike image of the fetus. Now, between those 2 images, I've just pressed a button. I've done no other processing or rendering. I've just pressed a button that says realistic view, and I've seen this surface view. You can then apply image contrast enhancement. So you can get this almost lifelike image, so you see the outside boundaries and you can see internal structures as well. So it's called image contrast enhancement, so it allows this transparency whilst maintaining external borders. And then you can invert the image as well, so that fluid-filled spaces appear solid. Now, this is all well and good, but what are we looking at? And you can get all these images, but you need to know what you're assessing and what the anatomy is so that we can use it in a clinically useful way. The problem with these sorts of images is that we don't have a robust reference standard for them. And the reason for that is that typically when we think about using reference standards for anatomy, we think about embryology. Now, if you think about embryological sections, they're normally 2D, black and white sections, and they just aren't really the correct way or the correct standard that we need to interpret these images, because these kind of 3D lifelike images are very different to those. So when we first started using 3D in this way, we thought we need a better standard. And so we started collaborating with an amazing group of embryologists at the AMC in Amsterdam, and their work has been in creating 3D embryo models. Now, I'm going to really quickly talk you through what they've done, because I think it's important that you understand how their models were made, so that you understand why they're robust enough to be used for 3D comparative imaging. So they've created a 3D atlas of human embryology, and it's an atlas based on 15,000 sections of 34 embryo specimens from the Carnegie collection. So they went to the Carnegie collection, which has all these sections of all these embryos. They photographed every single section. They then uploaded them into a computer and aligned them to kind of recreate the embryo with these sections. They manually annotated every single section with every single anatomical structure that was present within it in a different colour, put these into a computer again, reconstructed them and modelled them to create 3D embryo models. And what they've done is they've created 3D embryo models for 12 Carnegie stages and put them into PDFs. And you can use them in a very similar way to the way that you look at 3D ultrasound. So all the structures are highlighted. You can scroll through these volumes in the same way as you can with a 3D ultrasound volume that you acquire. You can rotate them in exactly the same way. You can highlight specific structures that you want to see. So they're a very good way to look at imaging and embryology in a similar way to what we can do with 3D ultrasound. So this is just showing you how you can highlight. So I've highlighted the ribs and spine there, and so those have come more into view. And these are freely available on their website. So what we've posed to do was to use 3D ultrasound with these newer rendering techniques where we're not really sure what we're seeing, and using embryology as a gold standard to try and better understand the anatomy. So not only can we use the models, as you can see on the right there, we can also use the original histological sections from which they were derived. So let me show you some examples. Now we're thinking about anatomy and we're thinking about first trimester anatomy. This is a big paper done by Singalaki et al. It was of almost 100,000 women where they looked at non-chromosomal abnormalities at 11 to 13 weeks. And the ones that I want you to look at are the ones on the far left here. So these are the abnormalities that you should never miss at 11 to 13 weeks. And I would say that most of those you should never miss at 8, 9, 10 weeks either. And then the middle ones are those that are sometimes or potentially detectable. Now, this was done on 2D imaging and at 11 to 13 weeks. But I want to take it back and I want to go to 7 weeks and show you what's possible to see on 2D and 3D and how we might be able to cover some of these organ structures. So 7 weeks gestation, you'll all be used to seeing a 2D image like this. You can see clearly the head end, you can see a caudal end, and not much more. If you take a 3D volume, though, this is what you can see. So you can see the limb buds appearing, you can see the umbilical cord very clearly, you can see that this, the shape of the fetus is normal for this gestation, and we know that because we can look at the 3D embryo model of exactly the same gestation and compare them directly. By 8 to 9 weeks gestation, things actually change very rapidly. You're moving from the embryonic period into the fetal period, and the fetus is starting to look much more like you expect it to at later gestations. So the arrows there show you the limb buds, and you can also see things clearly like the physiological gut herniation. Now in 3D, you can see that the limbs have really lengthened between 7 and 8 weeks. You can clearly see arms, legs, elbows, knees, feet, and the shape of the embryo is much more like we expect it to be at later gestations. And I think it's quite amazing. And, I said to you at the beginning that we need to think about whether we're looking at the early first trimester or late first trimester. But even between 7 and 8 weeks, there's a huge change in the morphology of the embryo. And unless you appreciate what's normal, it's very difficult to then interpret the images that you're getting. 9 weeks gestation, you can see things like the fingers, and in that 2D image I showed you the fingers as well. So I'm not saying you just need to use 3D. The beauty of the 3D though is that you can see lots of structures in a single sweep. And you can see with the embryological model on the right there at the same gestation that the feet and hands are in their normal position in the midline as they often are at this gestation. So we've looked at the limbs. What other parts of the skeleton can we look at? Well, we can look at the spine. So the spine you can see very clearly actually from 9 weeks gestation. Now if there were a subtle neural tube defect we probably wouldn't see it, but if there was a large open spina bifida you would be able to see it at these early gestations, and so we should look. I remember when I first started this PhD, Professor Bourne said to me, if you keep looking, it's pattern recognition. You need to keep looking. Every scan that you do is an opportunity to assess the anatomy and to look, and the more you look the more you'll see abnormality. And it's true. So if you take a volume every time and if you look at the anatomy, even if you're not sure initially, you'll become more familiar with it, your eye will get used to it, and then you'll be able to spot patterns. So we've looked at the outside of the embryo, which you're all used to looking at. We're all used to seeing these lovely images of the embryo externally. I'm showing you, if we use a bit more image contrast enhancement, how you can get these kind of X-ray-like images and look at the fetal spine. What about inside the embryo, though? Because that's what we're really interested in as well, is the internal structures too. So with exactly the same rendering modes, you essentially just sweep through your volume. So you slice through your volume and you can look at internal structures as well. So here you can see the lungs, you can see the liver, you can see the fetal stomach. If you rotate the embryo, you can even see the diaphragm at these early gestations. If there was a large diaphragmatic hernia, you may be able to spot it. Now, I'm not saying you will for sure, but you might, because you can see the diaphragm there very clearly. Everybody who knows me knows that I'm totally obsessed with fetal kidneys. And the reason for that is, I know, but the reason for that is because I think it is completely bonkers that we don't assess the fetal kidneys until 20 weeks gestation. Bilateral renal agenesis is incompatible with life. Unilateral renal agenesis can often be associated with other abnormalities. So why don't we assess the kidneys early on? Because they're there. They've been there from 7-8 weeks gestation. So if we look at that fetal spine, if we just scroll through the volume, you come upon these two structures. And lo and behold, they are the kidneys. And we know they're the kidneys because we've got a morphologically matched volume on the right there. And you can see there are the kidneys there. And the structures above them are the adrenal glands, which we aren't actually typically used to assessing at 20 weeks because they're much smaller by that stage. But it's important to know that this is what they look like at this gestation. So again, and I keep saying it, but it's important to know what's normal at each gestation. What about earlier? So we've got 12 weeks on the left here. You can scroll through and see those kidneys. 11 weeks next to it. 10 weeks, you can see the kidneys very nicely. And 9 weeks as well. So at all these gestations, you can see the kidneys. Start looking for them. If they're not there, refer to your fetal medicine unit early, because these women can be assessed early and can be given more information about their pregnancy much earlier on and make the difficult decisions that they may need to make as well. Head and face, difficult to examine in the first trimester, difficult to assess normality, but by 11, 12 weeks gestation, you can see the lens very clearly, you can see the profile. At 13 weeks, you can appreciate the different skull bones as well. The brain is a tricky one, and the brain is a tricky one at any gestation. Even in the fetal medicine unit, you see an abnormality in the brain at 20 weeks, you bring them back at 24 weeks, you bring them back at 30 weeks, you do an MRI at 32 weeks. It's a constantly changing organ, and it's difficult to assess. But there are things that we can see early on, and so we should be looking for them early on. You'll all be familiar with this traditional transverse view where you get this butterfly appearance of the choroid plexuses within the ventricles at this early gestation. But what else can we see? Because typically this is the only view that we look at of the fetal brain in the first trimester, even 12, 13, 14 weeks. This is 8 weeks gestation, and I've applied inversion mode here. So this is where you make the fluid-filled spaces appear solid, and this is the ventricular system. And if we compare it with an embryological model of exactly the same gestation and the histological section, we can mark up the different parts of the fetal ventricular system as early as 8 weeks gestation. So you have the lateral ventricle, the third, the aqueduct, the fourth, and the interpeduncular cisterna, which look very different to how they do at 12 weeks gestation or 20 weeks gestation, but they are there to be seen. This is 9 weeks gestation. Oh, the video's working. I didn't think it was going to. So very similarly, I scrolled through the volume, I hit inversion, and you can see the ventricles appear again. We can also model these as well. So the great thing about the 3D volumes is you can use them to create models, you can make 3D printed models, which are useful for educational and teaching purposes as well. And that's just an example of a model that was made from this volume, which was then printed. If you rotate the volume, and that was a sagittal section, and look at a coronal view of the ventricular system, it looks like this. And again, this slide's just here to highlight how different things look at 9 and 13 weeks gestation. Same structure we're assessing, looks completely different. So I think 3D's got something to add. I'm not saying that we're using it alone, because we're obviously never going to be doing a 3D scan without a 2D scan, but I think that adding 3D adds value. So it'd be very reasonable for you to say, now, Harsha, that's great. You've shown us pictures of embryos, but how often can you see these things? So I'm going to just show you just a snapshot of data from my PhD. So we did a study where we looked at women in the first trimester, and there was a group of women that we scanned every week from 8 till 17 weeks to look at how the anatomy changed during that time frame, and then a group of women that we looked at just in the first trimester at 12 to 14 weeks. In all the scans that we did a 2D scan, and then we took 3D volumes, and then we processed the 3D volumes with this rendering afterwards to see what anatomy was there to be seen. We used an anatomy checklist that's here on the left, which is the anatomy checklist that we use at the 20-week scan, with obviously the exclusion of the fetal heart. And then for each structure, we said, can we see it or can we not see it, and how confident are we that it's normal? We first created normal images for all of the structures using the embryology so that we knew what each structure should look like in the first trimester. And then here's a little bit of data. So the thing that I want you to look at are the dark grey bars. So that's if a structure was visualised, and this is across an entire scan between 8 to 17 weeks. And what we found is that if you used a combined 2D and 3D approach, which is on the far right here, oh, you can't see my mouse, on the far right here, we can visualise more structures than if we use 2D or 3D alone. And this held true at every gestational week up until 16 weeks. Oh, that's moved by itself. So using 2D plus 3D is better than 2D alone. So 3D has some value to add. This is a graph that shows you the fetal anatomy visualization at each gestational age from 8 to 17 weeks gestation. The pink bars are using a combined 2D plus 3D approach. Now I've put 80% in there, so 80% of structures visualized, and that becomes important when we're looking at the time of the first trimester dating scan. But actually, even if you look before that, at 10 weeks gestation, we're at over 50% of anatomy that can be assessed at that time. So if we can see all of that anatomy, we should be looking for it at every scan. And this is just to show you that we did some reproducibility work and found that it was reproducible looking at these structures. So I've shown you lots of normality, but the point of doing all of this and using 3D is to diagnose abnormality. Now, my study was not powered and not aimed at assessing abnormality, but obviously there were some, fetuses that we scanned in that time where there were abnormalities present. So on the far left here, you've got an acrania anencephaly sequence, exencephaly sequence, and you would most likely be able to see that in 2D, but if you do a quick scan, you might miss it. But in 3D, you can see it very clearly. You've got a very gross hydrops there in the middle. This is a case of bilateral renal agenesis at 11 weeks gestation there. This was a patient who came to see us. She'd had a previous termination for Fraser syndrome, which includes renal abnormalities. Came to us for an early scan. We diagnosed it or suspected it at 11 weeks. She got seen in our fetal medicine unit. It was diagnosed and confirmed at 13 weeks, and she went on to have a termination. And we actually received a really lovely card from her to say thank you, which was unexpected because she'd been through such a difficult time. But she said she didn't have to wait till 20 weeks like she did in the previous pregnancy to have a termination. So, it has an impact, it has an effect. We know that the later on in pregnancy you have a termination, the higher not only the morbidity, but the psychological impact on a woman and her partner. So we should be looking early. So what's the potential of ultrasound? I've shown you that actually ultrasound can do quite a lot, but can we take it even further? Is there even more to learn from ultrasound? Now, with the group that we're working with in Amsterdam, they have a fetal biobank set up in Amsterdam. So in Amsterdam, most women who have a miscarriage or opt to terminate pregnancy have medical management, which isn't really the case here quite as much. And they very generously donate their embryos and fetuses for research. And so they've got a huge biobank of specimens. And we wondered if there was a way that we could start scanning those embryo and fetus specimens to learn a little bit more about abnormality. How do we do that? Well, we had to first set up an environment where we could mimic the imaging that we get in utero. So the neonatologists and people kind of interested in neonatal imaging will often scan specimens, but they scan directly onto the embryo or fetus specimen, but then you can't get 3D images in the same way because you need this water interface with your ultrasound to create those 3D volumes with external rendering. And so we created a 3D scanning environment which would enable us to obtain images that were akin to the in utero images that we were used to looking at and our eyes were used to looking at patterns within them. And we found that we could do this. So we would put the embryo specimens within the water bath. We would use the same ultrasound machine and ultrasound probe that we used in utero. And we found that we could get very, very similar images of fetuses, not only externally, but internally. So you can see kidneys here on the left. You can see the kind of the circles or the holes of the fetal stomach and bladder, view of the fetal spine and the diaphragm as well. So these are all ex vivo images. And they obviously have some abnormalities within the bank as well. So these are conjoint twins here. This was a case of Turner syndrome, and you can see the high drops there. So that's the kind of potential in terms of looking at ex vivo specimens and learning more about what abnormality looks like on 3D ultrasound in the hope that we can then apply those patterns to in utero imaging. But can we take it even further? Now, within the world of post-mortem imaging, there have been really rapid advances over the last few years, and lots of women are now opting to have the kind of non-invasive post-mortem imaging. And the imaging that they are using primarily in this field now is micro-CT. I want a hands up before I show the video. Has anybody seen any micro-CT images at early gestations? Okay, get ready to be wowed. So this is courtesy of the team in Amsterdam. So this is at 8 weeks gestation, and this is a micro-CT volume. And it is remarkable, the detail that you can see. And it's really going to add to our understanding of what's normal at each developmental gestation in the first trimester, because we've never had imaging like this before. Now, how does this apply to us? Because obviously we're not going to be doing micro-CT on our pregnant women. But it's a tool that will help us better understand what normal anatomy is and how our imaging can be improved. And so we wondered if there was a way to look at this and to use this and to help it facilitate the way that we're doing our imaging. And so what we did is we've created a study there where we're performing ultrasound and micro-CT on exactly the same fetus specimen so that we can then directly correlate the imaging that we're seeing. So the fetus specimens get fixed first. We then perform ultrasound on them. They then get put in iodine for contrast staining, and then they have a micro-CT. So this is a 3D ultrasound of a fetus specimen. This is then a micro-CT of exactly the same specimen, and then you can mark up the anatomy. So I'll show you a couple of more examples. So this is at 13 weeks gestation. So the image on the far left is the 3D ultrasound. In the middle is micro-CT, but with micro-CTs you can create volumes in a similar way that you can with the ultrasound as well. So that's a volume of the micro-CT in the middle. So if I scroll through both, on the left you can really clearly see, the kidneys, you can see the lungs, and similarly you can see that in exactly the same way on the micro-CT. Now the beauty is that it's the same specimen. So if you see a structure on 3D ultrasound and you think, no idea what that is, you can go to exactly the same section within the micro-CT and know for sure that that is the anatomical structure that you're looking at. Similarly here, you can see the liver very clearly, the heart and the lungs. So this is at 9 weeks gestation. Again, I just want to show you here, this is actually my final slide, just to show you sort of the power of ultrasound, especially at these early gestations. So at 9 weeks gestation, if we scroll through this volume, we then apply this crystal view, so we apply this post-processing where you get this further image contrast enhancement. You can see a huge number of structures appear. If we compare it to one of these embryo models again, you can see the esophagus, you can see common cardinal veins, the umbilical vein very clearly, the aorta. So it's just highlighting all these structures are here, the anatomy's there, the fetus is developed, the embryo at 9 weeks has got pretty much everything there that it's going to have there at 36 weeks. So we should start looking at that anatomy and start assessing for normality and then picking up abnormality. This is a lovely quote that I've shamelessly stolen from Bernadette, my embryology colleague in Amsterdam, that she puts on her slides, which I'm in complete agreement with, because I think that without the embryology, we wouldn't be able to do any of the imaging or have any of the understanding that we have. So I hope that you have seen some of the benefit of 3D ultrasound. I hope you'll go away and start using the 3D ultrasound on your machines. There is a learning curve, obviously in the same way as there is with 2D ultrasound, but it's very, very easy to take a 3D volume in the first trimester. It's essentially a click of a button. And once you get used to using the rendering settings on your machines and looking at specific planes, it's actually very easy to do. We have got a website called 3dultrasoundatlas.com, which has got some reference images on there that we are building and adding to all the time for those of you interested. And just a big thank you to the team that I've worked with at Imperial, Professor Bourne, Professor Lees, and the team at the Amsterdam University Medical Centre as well. Thank you.
Harsha, many thanks. That's a great talk. And do you have any questions from the audience at all?
And I should say, if there's anybody in the virtual audience, you can put your questions on the Slido, please.
Do you have any questions? No.
I do, actually, Harsha. So in early pregnancy, I mean, this all started with us scanning in the unit and starting to notice things because of how wonderful both the resolution of 2D and 3D imaging has become. But from our perspective, practically, as scanning in early pregnancy, I think there is one thing that we can actively do now if we do see a problem, not just refer to fetal medicine. And I just wonder if you want to comment about what we do in our unit when we see an abnormality and sadly the pregnancy miscarries, but the embryo looks unusual, I should say, and then we would offer cytogenetics and how that might help couples.
Well, I think exactly, information is power. And I think for so many of our couples, as you say, we will scan and we'll think something doesn't look quite right. And you might not know exactly what that is, but you can say this doesn't look quite right. And, we've all met women who have been through miscarriages and those who have been through multiple miscarriages. And actually the answer that everybody really wants is why. Why did it happen? And most of the time we're saying, we don't know, it's very common, it happens. It might be a genetic thing, it might be a structural thing, we're not sure. But actually, if you've seen an abnormality, even if you don't know exactly what it is, as Maya says, at least you can say, you have to be honest about it. And you can say, something developmentally doesn't look right. Now, it could be that it's just structural, or we know that often structural abnormalities are associated with chromosomal or genetic abnormalities. So maybe that's the reason why. And so we can offer cytogenetic testing, or you can opt to have cytogenetic testing. And it might not give us anything, but it might give you a little bit more information for the next pregnancy. But not even for that, just for your peace of mind and being given an answer as to the why. So I think that's really important.
Yeah, we often see, a hydropic embryo or sometimes acrania and encephaly, and these are good reasons to offer cytogenetics to couples.
Absolutely.
And in the UK anyway, I can't, obviously it's different worldwide, but for women who've had 3 losses, recurrent losses, or an abnormality detected on scan, they will offer cytogenetics, so it can be helpful. And I have one other question. So much of this is operator dependent. And I just wondered, I know it's always the thing that's going to come up, is how much you think in the future we can use some of this and apply it in AI and without needing somebody like you who's been scanning through thousands of volumes all the time for the last few years.
I think that's the beauty of the volumes, though, is that actually I think you need to define what normal is, which we've started to do, and that work's being taken forward with the group in Amsterdam. And once we know what normal is, then AI can take over and highlight the things that might not be normal. But I think this is the groundwork that needs to happen first, because it's really, really important, obviously, that we defined what normal is so that we can then assess for what is abnormal. But the beauty of the volumes is that, all the information's there, and so AI can very easily take a volume and dissect it and also find the planes that you need to see.
Because, that's the reverse, is worrying people or telling people they've got something. That's catastrophic.
Absolutely.
So the data really has to stand up in bigger studies, doesn't it?
For sure, absolutely.
And obviously for the team in Amsterdam, the beauty of collaborating with you and doing the study is you actually know what happens to the babies at the end. They don't. They just have the specimen, not knowing what was the final outcome, if that makes sense. But actually knowing through the work that you've done and following the pregnancies prospectively, knowing what happens to the
Yeah.
babies when they're born, is kind of part of
Yeah.
that defining. I hate the word normal, but defining normality or the range of normal,
Absolutely.
which is so important in this kind of work.
I mean, I think if the pregnancy miscarries and you say, fine, we'll do cytogenetics, I think the issue is more, well, in a sense, management-wise, it's quite difficult if they don't miscarry and you think there's an abnormality. And the question is, what is then the reference standard? Because obviously you may, in an early pregnancy unit, not infrequently say, this embryo looks a bit odd.
Yeah.
And then it's like, well, what do we do about it?
Yeah.
Do we tell the patient? Do we do a 3D scan? What, at the moment, what's the place of that? Because if you go to fetal medicine and it's like 8 or 9 weeks, they go, yeah, great, bring it back at 11 weeks. 9 times out of 10, they're not going to be very interested in looking at it. So in practical terms, do you think that needs to change? And do you think actually even in fetal medicine, they're geared up to say anything useful at that stage anyway? Because they're going to kind of say, well, we don't kind of see things at this stage. We're not happy to actually make a diagnosis. So this idea of saying, great, we're going to tell people at 8 weeks you've got this problem is going to get deferred anyway.
Yeah.
So how do you change that paradigm? Not an easy.
I think it's tricky. I think that within fetal medicine, everything is moving more towards the first trimester. NIPT is being used a lot more frequently. I think everything is shifting already. So I think it's just the whole concept of information being important. So I don't think at 8, 9 weeks, I don't think we should be saying this baby's definitely got an abnormality. But I think that we say, let's bring you back for a scan in a couple of weeks. Let's assess things. We know that things change so quickly. And I think that as fetal medicine comes more towards the first trimester, hopefully, my hope, is that they will also become more comfortable scanning these women much earlier on in pregnancy and giving diagnoses, especially for the major abnormalities, much earlier on, and not saying you've got to wait till 13 weeks to have a CVS, for example. I think we've got a way to go, though, still. But I think that it's the way that medicine is moving. Everything, in terms of scanning, everything is moving towards the first trimester. So I'm hoping that there will be kind of a shift in the landscape over the next few years. But I think at the moment, you can't see something at 8 weeks and say this baby's abnormal. Absolutely not. But I think that you can bring the patient back and we can learn more and we can have MDTs and we can look at them together and we can have a view on what we think is going on. And I think even saying to the patient, we're a little bit concerned, we would like some further input, or we would like our specialist colleagues to see you a bit later on in the pregnancy, is still information. Because I think the worst thing that happens is you see somebody fall bleeding a couple of times in the first trimester and you scan them and everything's great and there's a heartbeat and go off and have your 12-week scan, and then a major abnormality is picked up at 12 weeks. And of course they're going to think, but everything was fine at 8 or 9 weeks. I got seen twice and got told everything was normal. And it probably wasn't normal then, but we've either not picked up on it or we have and we've not told the patient. And I think that's where things need to change as well.
Yeah, but you cite some abnormalities you ought to see.
At 11 to 14 weeks.
11, 14 weeks. So how many of those ought you see or should one see earlier?
The majority.
Yeah, exactly. So at some point, the training has to change.
Absolutely.
It's a question of how you make that happen over time. And you've got to have very good data because, if you're introducing this almost as a screening test, then that becomes a very different issue.
Yeah.
Huge studies for that.
At the moment it's kind of opportunistic. And you see something and it's like obviously acrania or something, then fair enough. But it's going to be, one would say it's perhaps quite difficult at the moment to envisage asking people in an early pregnancy unit to do to scan because one could end up with quite a few problems.
And this is very much, within a research setting at the moment as opposed to widely being used. But I think that everybody's got an opportunity to start learning about it because I think that's the way things are moving. So get ahead of the curve.
Well, I think what you're saying about learning is important because actually probably or doing this exercise, your foundations in embryology and scanning and what you should see is going to be superior. And then, one wonders, therefore, if things are being pushed earlier, whether we should all be looking, basically kind of learning this 3D atlas and learning this anatomy as part of our basic training in ultrasound and early pregnancy. I think that's probably the way that we're going to go.
Completely.
And maybe the way we should go, because if we can see those things, we should look for them, as you said.
Yeah, but remember, I mean, I'm so old that I remember working at King's and Shraga Rotem actually came over from Israel and spoke to Kepros and talking about the fact he'd identified these thicknesses at the back of the neck and so on. And of course, the rest is history. But at that time, doing a scan to 11 to 14 weeks, everyone thought was kind of like, well, why are you doing that?
Yeah.
It wasn't done. It was all about later scans, and so that has evolved over time. And of course, now we're talking about pretty well doing a full anatomy scan at 11 to 14 weeks, and pretty much all you don't look at that point is the brain and the heart, right?
Mm-hmm.
But so it's logical that as ultrasound improves and people's knowledge of the embryology, because what's quite surprising is that a lot of assumptions are made about the anatomy in the first trimester, but no one has actually done the embryological reference to say that actually that's what we are actually looking at. We've made assumptions about what we're looking at based on scanning later on. So this is essential work which we have to do if we're going to end up moving things earlier and earlier, which I think, as you've already said, is important for people, because the longer if you have to interrupt a pregnancy at 20 weeks or whatever, I mean, it's bad enough at any time, but that's just awful.
Of course. We have one question, Harsha, sorry, for online, and then we can then move on with the next speaker.
Okay.
Does thermal index and mechanical index increase while using 3D?
No, it doesn't. ISWOG have got a very good safety paper on it as well. So when you're doing the 3D scanning, it's akin to doing a 2D scan, and it just takes multiple slices. As long as you're always sticking by your ALARA principles on your machine, the thermal index won't increase by doing a 3D volume. For those of you taking 3Ds, particularly in the first trimester, you acquire a volume within about 2 seconds. So the only thing is, don't put power Doppler or colour on in any way, shape or form in the first trimester, but take 500 3Ds if you want. No, don't take 500. Take 5 or 6.
And don't use pulse Doppler to look at the heartbeat. I know
No,
it's a number of times
don't use it at all.
You even see papers with people putting pulse Doppler on embryos and published, and you just think, what are you doing? It's just not a good idea.
Yeah. Perfect. Thank you
Thank
so
you.
much,
Thank you for
Harsha.
having me.
Wonderful
Thanks
as
very much.
always. Thank